hypoglycemia. And again, acute complications, we have to take in history that is there any history of diabetic ketoacidosis or HONG in last 3, 6, or 12 months, and we have to give their scores accordingly. Microvascular disease complications and comorbidities, if there are any and they are unstable, then straight away a score of 6.5 will be added. And if they are there, but stable ones, then 2. We have to see the renal complications. We have to see the EGFR. If there is a severe renal compromise, then straight away 6.5 score makes the high risk. But if it is in between 30 to 45, then 4 points will be added, 45 to 62 points, and if more than 60, that is normal. Again, it is important to stress out here that pregnancy is, again, a risk factor independent of diabetes. So if a person who is having diabetes mellitus and is pregnant and is not meeting the targets, then we have to assign 6.5 points to that patient. And pregnant within targets, then it's still 3.5. Frailty and cognitive functions have also to be taken into account. If a patient is having impaired cognitive function or is frail enough, then we have to assign 6.5 points. And if more than 7 years old with no home support, then 3.5. Talking about physical labor, there are some professions in which there is involvement of highly intense physical labor. So we have to give 4 points to those. Moderate intense physical labor, then 2 points, and no physical labor, then 0. We also have to ask the patient about previous Ramadan experience. If overall the experience was negative, then we have to add 1 point to that. And the last point to be considered in risk stratification is fasting hours. So that depends on locality where the person is living. If the fasting hours are equal to or more than 16, then we have to add 1 point to that. Now we have to individually for every patient and then see where the patient lands. If the score, total score, falls in between 0 to 3, then it will be considered low risk. And the medical recommendations are that fasting is probably safe for them, but still patient has to get medically evaluated, has to get medications adjusted, and a strict monitoring of blood sugars should still be done. And the religious recommendations are also the same, that fasting is obligatory for them, except for the conditions in which they cannot take the burden, physical burden of fasting, or they have to take some necessary medications during the daytime. If the total score falls in between 3.5 to 6 points, then fasting safety is uncertain. But still, there will be many of those patients who will be opting to fast with this moderate risk. So they have to get medically evaluated, have to get medications adjusted, and they should follow strict monitoring of blood glucose. So religious recommendations here leave this matter to the patient, that they may choose to fast if they're concerned about their health after consulting the doctor, or they may even not do it. So if anybody is having a score of more than 6, then it is a high risk. Both the religious and medical recommendations are that fasting is not advisable for such kind of population. And as previously told, the pregnant and breastfeeding women have the right to not fast regardless of whether they have diabetes. So once the patient had initial assessment, for example, it was the last year that he was not allowed to fast. But this thing can change because there are certain modifiable risk factors, such as glycemic control, frequency of sugar monitoring, or with the development of a new complication. So the risk can change and should be assessed every single year before Ramadan. And so another strategy to ensure the safety in Ramadan is blood glucose monitoring. Now the patients ask that how many times should we check our blood sugars? And I would like to mention it here that it does not break one's fast while checking blood sugars or getting the dose of insulin. So frequency of blood sugar monitoring depends on many factors, including the type of diabetes and the current medications that should be carried out. And but again, it should be carried out regularly. For those at the low to moderate risk, this may be either once or twice a day or as per the need. And those at the high or very high risk and is still opting to fast, should check their blood glucose levels several times a day. So it is at least 6 to 7 times that they should check their blood sugars if they are falling into the higher risk category, like pre-dawn meal before suhoor, then in the morning, then in the midday, and then in the mid-afternoon, pre-sunset meal, that is before iftar, and then 2 hours after iftar, and at any time when there are symptoms of hypoglycemia or feelings of being unwell. So another important point to educate our patients about is when to break their fast. So all the patients should break their fast if their blood glucose level is less than 70 milligram per DL. And if the blood sugars are in between 70 to 90, they should recheck it within 1 hour again so that there's a chance that they may go in hypo. If blood glucose levels are more than 300, again, they should break their fast, and symptoms of hypo or hyperglycemia or acute illness occurs, then they should break their fast for the safety concerns. We should also educate our patients about the symptoms of these complications, like hypoglycemia, the different like sweating, shaking, fast spells, and etc. High blood sugars, and then dehydration. We have to tell them that if they feel increased thirst, not going to toilet as often, and they have got dry mouth, lips, and skin, that may be a telltale sign of dehydration. And also about diabetic ketoacidosis, especially in type 1 diabetes patients, that they may have fruity scented breath, dryness of mouth, excessive thirst, that may be indicative of diabetic ketoacidosis, and they should immediately check their blood sugars at that time. So once person has developed hypoglycemia, so we have to educate that they should manage their hypoglycemia by following this rule of 15, in which they have to eat or drink 15 grams of carbs, wait for 15 minutes, check their blood sugars, and if the sugars are less than 70 milligram per DL, they have to repeat step 1 to 4 all over again. And now, what kind of food or drinks contain 15 grams of carbohydrate? So it is 4 ounces of fruit juice or soda, not diet one, 4 or 5 pieces of hot candy, or 3 teaspoons, that is equal to 1 tablespoon of sugar or honey. So once SMBG is normal, now they have corrected hypoglycemia, but still they should be advised to take a meal or snack to prevent recurrence of hypoglycemia. So hypoglycemia is divided into 3 different levels according to their severity. We have talked about mild hypoglycemia. So moderate hypoglycemia when blood sugars are less than 54 and more than 45. In that condition, people may be able to help themselves, and it is at this point that neuroglycopenic symptoms start to develop, like lightheadedness, tingling around mouth, feeling vacant. At that time, what they have to do is they should be given 20 grams of carbohydrates. And the foods or drinks, just like 6 ounces of juice or 1.5 tablespoon of sugar or honey, or if dextrose, if available at home, should be given. And if the hypoglycemia is severe, that is blood glucose levels are equal to less than 45, in that condition, if the patient is conscious, then we can give juice around 8 ounces orally, or 30 grams of sugars, that is equivalent to 2 tablespoons of sugar, or 4 ampoules of 25% dextrose water. And if it is severe enough to cause unconsciousness, then obviously the patient cannot take it by mouth. So we have to give immediate medical help. And we have to give 4 ampoules of 25% dextrose IV, or 50 mLs of 50% dextrose, or glucagon, 1 milligram of IM for adults and 0.5 milligram for a child. And it is important to educate the attendants and caregivers and family members of people with diabetes regarding the usage of glucagon. So as already discussed, that we had to give 0.5 to 1 milligram of glucagon according to their age. And it leads to recovery of consciousness in around 15 minutes, but that may be followed by marked nausea or even vomiting. It can also be given intranasally, but the dose then will be 3 milligram. And it was also seen in this study that as compared to 100% recovery in people who were given IM glucagon, there was 98.7% recovery in those who were given intranasally. And mean time to success was also slightly delayed by around 3 minutes. So that brings us to presentation. But before that, I would like everyone to kindly go through this and answer the questions. So the scenario is of 51-year female who is teacher by profession, diagnosed with type 2 diabetes mellitus 10 years ago. Her weight is 74 kilogram, BMI 28 kilogram per meter square, and her BP is 125 by 76 millimeters of mercury. She's currently on metformin, empagliflozin, and glimepiride. She attends your clinic a week before Ramadan, and her latest A1C is 9.3%. Her renal function is normal. She experienced symptoms of hypoglycemia twice during busy days at work last week. She always fasted Ramadan, and she's keen to fast and as per your advice. So the questions that we have to answer are, should she be advised to observe fast or not? And what is the level of risk for this patient if she opts to fast? So if we go back to that risk stratification chart, then we can see that she has got duration of diabetes of around 10 years. That will be adding 1 point. She had 2 recent episodes of hypoglycemia during her busy days last week. So 3.5 scores will be added further. Her A1C level was 9.3%. So it gives her 2 more points. And she is on glimepiride, so that it's 0.5 more points, totaling to 7 points for her. And if we recall that if there are more than 6 points, it is a high risk. So she should not be advised to fast in this condition with Ramadan. But things can change next time. Maybe she has got better control of her hyperglycemia, and maybe she is off certain drugs that can cause hyperglycemia. So thank you so much for your patient listening. I would like to end my presentation with this verse from Quran, in which Allah says, "La yukallifullahu nafsan illa wus'aha." Allah does not burden a soul beyond its limits. So thank you so much.
Out following a proper diet plan, so it will not be wrong. So and in Ramadan, it is exceedingly difficult because of the kind of food we consume in sehris and iftaris. So let's begin and see what can we do. This is the outline of my presentation. Ramzan provides us ideal opportunity to channel our strength and discipline. And this strength and discipline is also needed by people with type 2 diabetes to comply with medical nutritional therapy, maintain optimal glycemic control beyond the month of Ramzan. And here I would like to add that MNT is associated with HbA1c decreases of 1 to 1.9% in type 1 diabetes, 0.3 to 2% in type 2 diabetes. Dr. MNT in Ramzan has been shown to improve fasting blood glucose and triglyceride levels and rate of serial monitoring of blood glucose pre-dawn and pre-bed. And it includes pre-Ramzan education and individualized energy and macronutrient prescriptions, just like So main aims of medical nutrition therapy during Ramzan fasting are to ensure that individuals with diabetes mellitus consume an adequate amount of calories and macronutrients during the non-fasting period to prevent hypoglycemia during the fasting period, and equally distribute their carbohydrate intake among meals to minimize postprandial hyperglycemia and hypoglycemia as well. And healthcare professionals should give consideration to comorbidities like hypertension and dyslipidemia also while formulating MNT plans. So main aims of pre-Ramzan visit are to provide individuals with diabetes mellitus a modified nutrition plan that improves glycemic control of patients with diabetes, help overweight and obese people to successfully and safely lose weight during Ramzan, adjust their anti-diabetic medications, encourage proper and safe levels of exercise and physical activity, help them recognize the warning symptoms of dehydration, hypoglycemia, and other possible acute complications, just like Dr. Yahya told these warning symptoms already, and enforce the importance of blood glucose and body weight monitoring during Ramzan. Many diabetes-related risks can be minimized through proper nutrition, like hypoglycemia, hyperglycemia, dehydration, especially when fasting hours are longer and hot climates, weight gain, electrolyte imbalances, acute renal failure, especially in elderly and those having impaired kidney function. Unhealthy eating habits in Ramzan include consumption of unusually large meals at iftar that can comprise up to or more than 1,500 calories, and high intake of processed carbohydrates and sugars, consumption of desserts loaded with sugar, and frequent snacks and large portions of high glycemic index carbohydrates at sehri, like white bread or naan and rice and sweetened dairy products and low breakfast cereals. So they all lead to severe and prolonged postprandial hyperglycemia. Then eating at fast speeds, which frequently leads to overeating because it takes 30 minutes for satiety signals to reach our brain. And eating too early or skipping meals altogether at sehri, it can give a hypoglycemia before iftar, especially if fasting hours are longer. And then frequently eating fried foods and changes in physical activity can lead to weight gain. Ramzan provides a good opportunity for overweight and obese people with type 2 diabetes mellitus to lose weight and significantly improve glycemic control and reduce their cardiovascular disease risk. Optimal target of weight reduction is 0.5 to 1 kg per week. Now, this is the table of calorie and carbohydrate distribution during Ramzan. And let me use a pointer. No, I think I will do without a pointer. So at Sehri, 30 to 40% of calories should be consumed, and it is equal to 3 to 5 exchanges of carbohydrates. And you can see below that one carbohydrate exchange is equal to 15 grams of 15 gram of carbohydrates. And then the main iftar meal should be of 40 to 50% calories with 3 to 6 exchanges of carbohydrates, and snacks should comprise of 10 to 20% calories. And you all know that 1 gram of carbohydrates gives 4 calories. Now, this slide is showing the basic carbohydrate servings we can have, and each of the items mentioned in this list is equal to 15 grams and gives rise to provides us 60 to 80 calories. So it can be 1 slice of bread or half cup rice or half cup cereal or 1/3 cup cooked pasta. Now, what are simple carbs and what are complex carbs? So complex carbohydrates are recommended because they are high in fiber and they digest slowly, and they have a low glycemic index, and they give rise to less postprandial hyperglycemia. And they include whole wheat bread, brown rice, oats, semolina, and beans, chia seeds, starchy vegetables, fruits. So we should avoid simple carbohydrates like white bread, white rice, cookies, and ice creams, and sweetened drinks. And this is the picture of guesstimating. It's a crude method of estimating portion sizes by using hand. So a clenched fist is equal to is approximately around 1 cup, and a cupped hand is half cup. and an open palm is 3 ounces. That is mostly used for meat and fish. And a thumb is equal to 1 tablespoon, and tip of the thumb is equal to 1 teaspoon. So these are the caloric targets during Ramzan for males and females. For males, there is no cutoff of height, but for women, it is different for women who are more than 150 centimeter and who are shorter, less than 150 centimeter. So this is another table of caloric diet. According to this table, you can see that 1200 kilocalorie per day plan is recommended for weight reduction in women who are less than 150 centimeter tall. And 1500 kilocalorie per day plan is for weight maintenance for shorter women who are less than 150, and weight reduction for women who are more than 150 centimeter. And then 1800 kilocalorie per day plan is for weight maintenance for taller women and weight reduction in men. And 2000 kilocalorie plan is for weight maintenance in men. I want you people to remember this. So coming on to the Ramzan nutrition plan, it's a web-based application designed to help healthcare professionals to individualize medical nutritional therapy for people with diabetes who are observing fasting, Ramzan fasting around the world. And it's also a useful resource for individuals with diabetes who do not have access to healthcare professionals. So we can assess this nutrition plan by going on to this website that I've mentioned, daralliance.org. And the healthcare professional can select their country and can gain country-specific recommendations. Currently, Pakistan is not on the map, and the work is under progress, but we can take help from other countries. So when you go to this website, it will ask whether you are a practitioner or patient, and then whether weight loss is required or weight maintenance is required, and what is the gender and what is the height. And then it gives a whole 7-day plan of sehri, iftari, and snacks. And each day plan is different. So if we click on one of these, it will give a sample of like iftar meal or sehri meal. And you can see that it's a 1500 kilocalorie per day plan for that is weight loss for women. And it is showing the calories and the carbohydrate exchanges and the distribution, as we know that 40 to 50% calories should be consumed at iftar and 30 to 40% at sehri. So now the Pakistani iftar items. So these are the most common food items on our iftar tables. And you can see that one large samosa has 308 calories and 3 small pakoras have 225 calories. Although there are some healthy options that we eat too, but no iftar is complete without samosas and pakoras. And then glasses and glasses of roux afzas and juices. And now you can see that it's very easy to reach 1500 calorie or more than that in a single meal, leaving nothing for sehri and snacks. So we should be mindful of it. Now coming on to the 10 principles of RMP. So number 1 is consumption of adequate amount of daily calories. Calories should be divided between sehri and iftar, not just iftar and then skipping sehri and going into hypo before breaking the fast. And then 1 to 2 healthy snacks can also be consumed, not necessary, but it's not necessary. So meals should be well balanced with carbohydrates of 40 to 50%, protein 20 to 30%, and fat 30 to 35%. Ramzan plate method should be used for designing meals. And what is the Ramzan plate method? This is a Ramzan nutrition plate, and it provides around 500 kilocalories per meal with 45% carbs, 20% protein, and 35% fat. So there is a plate with 1/4 showing the vegetables, which is 1 cup, non-starchy vegetables, which include cucumber and cabbage and tomatoes and broccoli, and 3 to 4 ounces of lean protein, which should be around the size of a deck of cards. 1 to 1.5 cup of whole grain rice, or 1 to 2 whole wheat 6-inch chapatis, or half cup of beans, lentils, or peas. So these things can be cooked or dressed with 2 teaspoons of oils, and 2 glasses of water and a small slice of fruit can be consumed. So the fourth principle, sugar-heavy desserts and beverages should be avoided, but moderate amount of healthy dessert is permitted, like a piece of fruit. Low glycemic index carbohydrates should be selected, like vegetables, fruits, yogurt, milk, and dairy products, which are high in fiber. Sugar and highly processed grains like corn and wheat flour and white rice should be avoided or minimized. Hydration is very important in Ramzan. Drink enough water and non sweetened beverages, it's essential. Sugary drinks should be avoided, and consumption of caffeinated drinks should be minimized. There's a very common trend of having tea after after breaking the fast. So take sahri as late as possible. There is a problem of lack of sleep in Ramzan, so many people try to eat much early to avoid wakening up for sehri, and consume an adequate amount of protein and fat because they have lower GI value, no immediate effect on postprandial blood glucose, and they induce satiety better. Iftar should begin with plenty of water to overcome dehydration and 1 to 3 small dried or fresh dates to increase blood glucose levels. Healthier snack may be consumed, which should be low calorie, like a piece of fruit, handful of nuts or vegetables. People with type 2 diabetes can break their fast with iftar snack, and then they can have iftar meal after Maghrib prayers. So this is the summary of the 10 principles. Okay, so this is the sample Ramzan nutrition plan for Pakistan that is mentioned in the guidelines, and you can assess those guidelines on IDFDAR website. So you can see that and take help from that. And I can only say that no samosas and pakoras are mentioned in this diet plan. So all options are healthy. So regarding exercise in Ramzan, rigorous exercise should be avoided, particularly during the last hours of fasting, because there is a risk of there's increased risk of hypoglycemia and dehydration. And people with diabetes should be encouraged to maintain their normal physical activity during Ramadan. Physical exertions involved in Taraweeh should be considered part of daily exercise activities, and individuals are more likely to achieve HbA1c targets and reduce body weight when they perform Taraweeh. What kind of exercise should be done? This I am talking about who are low risk type 2 diabetic patients and for us. So light to moderate exercise are generally safe, like brisk walk, slow jogging, cycling, and light machine exercises can be done. It is not recommended to increase exercise frequency, intensity, and duration, and high intensity exercises that increase pulse more than 150 should be avoided. And what are the best times for exercise? After the Taraweeh prayers at night, if somebody can manage, because adequate meals and water is consumed to help during workout, and an hour before breaking the fast, because there is flexibility of eating within short span, but again, there is a risk of dehydration and hypoglycemia. So in the end, there is a case scenario, and I would like your input. So 45 years old female who has type 2 diabetes for the last 5 years, presented to endocrine clinic 6 weeks before Ramzan. She's taking vildagliptin metformin 50/850 twice a day and glimepiride 2 mg once a day. On examination, she is obese, height is 154. Remember, I mentioned the height cutoff with BMI of 31.2. Her recent HbA1c is 8.6. So, which calorie plan will you advise her? A. Other answers like why A? B. So the correct answer is B because height is more than 150. A 1200 kilocalories per day is for women who are short, less than 150 centimeter. Okay. Now, which of the following is true while formulating nutrition plan for her? C. And? Okay, yes, it's all of the above. Okay. I think I'm successful in delivering my lecture to you people. Okay. Thank you very much. Ramadan Mubarak to everybody. And next, I would like to invite Dr. Paras and who is a consulting physician and fellow endocrinology at JPMC and MIDEM, and she will deliver a talk on management of type 2 diabetes mellitus in Ramadan.
Thank you, Dr. Sabha, for such a nice talk. So, since majority of diabetic population is of type 2 diabetes, it is very important that we as a healthcare professional be aware of what pre-Ramzan assessment to be done, how to adjust medications, and how to counteract the complications that can arise during fasting. So I'll be discussing management of type 2 diabetes during fasting. So this is the outline of my presentation. I'll be mainly referring to the IDF-DAR guidelines, and Dr. Yahya has already explained risk stratification in detail. Would just highlight that medication adjustment is the most important part, and those type 2 diabetic patients who are on insulin, so insulin dose adjustment, you all should be well versed with it. And post-Ramzan follow-up. So just a brief introduction. There are at least 463 million people living with diabetes throughout the world. And these are predicted to rise by 700 million by 2045. So diabetes in Ramadan guidelines mainly highlight the findings of following studies, and from the DAR MENA region and DAR Global Survey of Ramadan, which was conducted around 13 different countries in 2020. So evidences from all these guidelines will be highlighted in my talk. And all these studies involve participation of both type 1 and type 2 diabetes patients. So it is very important that pre-Ramzan assessment should be done, and ideally that is done at least 6 to 8 weeks prior to Ramzan. Dr. Yahya already mentioned these factors which should be assessed 6 to 8 weeks before Ramzan. So following are the 6 key areas. Risk quantification, whether the patient is falling in low risk, moderate risk, high risk. What is his motivation for blood glucose monitoring? Fluid and dietary advices should be given. Diet and exercise, as already mentioned by Dr. Sabha. Medication adjustment is very important, and when to break the fast. Warning signs, red flags of hypoglycemia should be well highlighted in pre-Ramzan assessment to all the patients walking in your clinic. So risk stratification, I will not go into the details of this. Dr. Yahya has already mentioned all these. So whenever there is a score of 0 to 3, the patient is falling in low risk, fasting is safe. Although highlight of today's session is that fasting is not really safe in all kind of diabetic patients. It is individualized assessment, and individualized plan should be given to the patients. If the score is of 3.5 to 6, that comes in the moderate risk, and you have to address accordingly. And safety and certainty should be explained to the patient. If the score is of more than 6, that is high risk, probably unsafe. So this scoring system has already been much evolved over a period of time. Previously, there was 4-tier scoring. Now it has been modified to 3-tier traffic light system according to the risk score. So the timings of SMBG, as already explained, 7-time SMBG should be advocated, or whenever there are symptoms of hypoglycemia or any acute illness. It is very important to emphasize this again and again to your patients. Most of the patients think that it is you cannot prick during fasting. So you have to advise that at any point of the time during fasting, you can administer insulin, you can prick, you can check blood glucose whenever you feel symptoms of hypo or hyperglycemia. So next we come to the medication adjustment. So we all know that what are the different classes of drugs used for type 2 diabetic patients. I will not go into the mechanism of individual drug. we'll just focus on the individual drug dose adjustment during Ramadan. So if patient is taking metformin only once daily, then no change in dose is required and advised to be taken at iftar. If pre-Ramzan patient is taking twice daily dosing of the metformin, again, no change is usually required. If diabetes is well controlled, he's tolerating metformin well, then no need to change dose. Advice for taking at iftari and sehri. If thrice daily dosing is patient is taking thrice daily metformin, then advice for taking morning dose before sehri and combine afternoon dose with dose at iftari. And if patient is on extended release metformin, then no change required, just advice for taking at iftar. So grossly, if we see metformin does not really need dose adjustment, except where thrice daily is being prescribed, combine afternoon dose with that of iftar dose. We all know that sulfonyl ureas are the insulin secretagogues, and they have potential for causing hypoglycemia, especially older generation sulfonyl urea like glibenclamide. So you have to adjust a little bit dosing of sulfonyl urea before Ramzan. If patient is taking once daily, advise them for taking at iftar. If well-controlled, blood glucose dose may be reduced. If twice daily sulfonyl urea is there on prescription, then keep the iftar dose same, and in well-controlled, sehri dose should be reduced to maybe 50%. Older sulfonyl urea, as I already mentioned, first generation sulfonyl urea like glibenclamide have a higher potential of hypoglycemia. So better to modify those to that of second generation sulfonyl ureas, such as glyclazide modified released, and glimepiride. These are preferred to that of glibenclamide. So, in a multinational study of around 1378 people of type 2 diabetes who were treated with sulfonyl ureas during fasting, approximately 1/5 experienced symptomatic hypo. And the percentage-wise, if we see, the number was highest with that of glibenclamide, followed by glimepiride and glyclazide. Next, I'll be discussing thiazolidinediones. Thiazolidinediones are basically insulin sensitizers, and they increase the sensitivity of insulin in the fat and peripheral tissues via the activation of PPAR receptor. And the main drug that has been studied extensively in this group is pioglitazone. So whatever data we have pertaining to TZDs is that of pioglitazone. So no difference in hypo events was observed between pioglitazone and placebo whenever they were compared with placebo. However, there was a significant weight gain with pioglitazone. As we already know, they have tendency for water retention and weight gain. Due to the low risk of hypo with pioglitazone, no dose modification is usually required and dose to be taken at iftar. And however, one thing very important, TZDs should not be started very close to the Ramzan. At least they take 3 months to act and then ideal HbA1c to be achieved. So it is important not to start TZDs very close to Ramzan, and those should be optimized at least 8 to 12 weeks. However, no dose modification is required in those who are doing already well with a good HbA1c control. Next is acarbose. Although we don't use this class of drug much, but it exerts its action on the blockage of alpha glucosidase enzyme, which in turn inhibits the breakdown of carbohydrates into the glucose, resulting in low glucose level. So no randomized control trials have been conducted on acarbose in type 2 diabetes during fasting. But due to the low risk of hypo, no dose modification is usually advised for this class of drug. Next comes short-acting insulin secretagogues. In this, we have repaglinide and netiglinide. And we have availability of repaglinide by the name of Novo norm. And these both are insulin secretagogues, stimulate beta cell to secrete insulin. Shorter duration of action makes them appealing for use during Ramzan. They can be taken just before Sehri and Iftari. And less hypo was observed in proportion to sulfonylurea. So there were multiple studies conducted in which they were compared to sulfonylurea. So hypo was less with repaglinide and metiglinide in comparison to sulfonylurea. However, daily dose may be either decreased or redistributed to 2 doses if patient is taking more than 2 doses. So just advice for taking before Sehri and before Iftari. We have newer class of drug, GLP-1 receptor agonists, and we are fairly using them in our practice. So GLP-1 receptor agonists, they mimic the incretin hormone and decrease the blood glucose level by increasing the insulin secretion in a glucose-dependent manner. Since they exert their action in a glucose-dependent manner, the risk of hypo is low with this class of drugs. But again, it can be increased when combined with either insulin or sulfonylurea. If appropriately dose titrated, at least 2 to 4 weeks before Ramzan, no dose modification is usually required. So I'll be referring to the few studies which were conducted on the different drugs belonging to this class. Liraglutide, when it was compared to sulfonylurea, and while patients were already taking metformin, it was seen that the patients falling in the liraglutide arm had less hypo than sulfonylurea. HbA1c control was better and weight reduction was better. We know that sulfonylurea result in the weight gain, so we had the benefit of weight reduction with liraglutide. Exenatide was compared again with gliclazide, and it led to the increase of weight of 0.68 in the arm of gliclazide. However, lixisenatide, when it was compared with sulfonylurea, while patients were already taking metformin and insulin, so fewer events were seen with lixi and insulin than with insulin and sulfonylurea. And however, there was no difference of HbA1c and weight change. So just to emphasize, GLP-1 agonist, if appropriately dose titrated before Ramzan, risk of hypo is low. Next comes the DPP-4 inhibitors. DPP-4 inhibitors also exert, they kind of exert similar kind of action to that of GLP-1 agonists, mimic incretin hormone and resulting in glucose-dependent insulin secretion, decrease release of glucagon. So DPP-4 inhibitors also do not require dose modification. In this class of drugs, we have availability of certain drugs like sitagliptin, vildagliptin, and if patient is appropriately dose titrated, well controlled, then no need to modify dose before Ramzan. Less hypo was observed with this class of drugs. And as you can see, vildagliptin was associated with a greater reduction in weight than sulfonylurea. Now I'll be discussing SGLT2 inhibitors. SGLT2 inhibit the absorption of glucose via the proximal convoluted tubule, and they should also be started at least 2 to 4 weeks, not just close to Ramzan, because it can lead to fluid imbalance and disturbance of fluid homeostasis. So it is important to adjust them 2 to 4 weeks at least. Once daily dosing is done usually, and those should be taken at iftar time. And if they are mainly being used for cardiovascular protection or renal protection, then induction should be done with a lower dose possibly. Increase the fluid intake during non-fasting hours, and they do not require dose modification. However, if an individual is on multiple drugs, then doses be reviewed to avoid hypoglycemia. So there are few trials with dapagliflozin, and it was seen that hypo was reported in only 6.9% in the arm having SGLT2 inhibitors. Postural drop was seen in 13.8%, versus 3.8% in control group. So it is important to maintain fluid homeostasis very well while patient is taking SGLT2 inhibitors. If patient is on 3 or more than 3 anti-diabetic agents during fasting, they should be counseled regarding diet, lifestyle, and dose modification. Those on both insulin and sulfonylurea are at high risk of hypoglycemia, and dose reduction should be advocated. And newer technologies, now we have availability of freestyle libre. CGM monitoring can be done through that. So patients who can afford and who have access to these technologies should be advised to use them for healthy and safe fasting. Now I'll be discussing insulin dose adjustment. So insulin use during Ramadan, those patients of type 2 diabetes who are using insulin should be advised regarding the dose modification, how to counteract hypo, and what kind of insulin regimes are better to be used. Analog insulins, these are newer insulins, we have availability of them here. They have lower risk of hypo and better postprandial control in comparison to the regular human insulin. They are injected 15 to 20 minutes before meal, and it is recommended that individuals who wish to fast be switched to analogs during fasting. Administration of any kind of insulin via any route does not cause breaking of fast. So this should be explained to the patients whenever they come for pre-Ramadan assessment. So how to adjust dose for basal and bolus insulin? We know that there are different kind of basal insulin with different half-life. So if patient is using any kind of basal insulin like NPH, Detamir, Glargine, or concentrated Glargine or Deglutec, concentrated Glargine U300 and Deglutec have relatively longer half-lives in comparison to NPH and Detamir. And if patient is taking once daily, then advised to reduce the dose by 15 to 30%, and basal insulin should be taken at iftar if patient is taking once daily. If twice daily, as sometimes those who are on conventional basal insulin like NPH, Detamir, or Glargine U100, and we can prescribe twice daily dosing of these insulin, then they should be advised to take usual morning dose at iftar and reduce the evening dose by 50% and take that at sehri. Short-acting insulin, which are taken pre-meals, just before meal. So normal dose at iftar, omit the lunchtime dose as there's no lunch, and decrease the sehri dose by 25 to 50%. Insulin titration should be very well explained to the patients. Whenever patient is feeling symptoms of hypoglycemia, or during SMBG monitoring, if glucose comes to be less than 70 milligram per deciliter, advise for reduction of both basal and bolus insulin by 4 units. Desirable target is 90 to 126. If a patient is on this target, continue the same dose which he is taking, or reduce or increase as mentioned here. If symptoms of hyperglycemia or blood glucose is more than 200, increase the dose of basal and bolus by 4 units. Remember that one change should be made at a time, and this change should not be, this titration should not be done every day. It should be done after every 3 days, not before that. Otherwise, there is stacking of insulin resulting in hypoglycemia. So insulin titration should be advised after every 3 days, not daily. However, dose can be reduced at any point of time, or whenever patient feels symptoms of hypo, dose can be reduced. So dose adjustments for pre-mixed insulin. Pre-mixed insulin are not a good idea for patients who are fasting. But if somebody is well controlled, comfortable, affordability is one of the reasons, then this is the way to adjust pre-mix insulin. If patient is taking once daily dosing, take same dose at iftar. In case of twice daily dosing, advise for taking same evening dose at iftar and reduce the sehri dose by 25 to 50%. If thrice daily dosing is there, then omit the lunch dose, adjust iftar and sehri dose according to the carbohydrate contents, insulin carbohydrate ratio, and insulin sensitivity factor, which will be explained in the upcoming presentations. And this dose titration should be done every 3 days, not frequent than that. Again, this is the same titration for premixed insulin. If patients experiencing symptoms of hypo or less than 70, reduce the dose by 4 units. Or if hyperglycemia is there and sugar more than 200 during fasting, increase the subsequent dose by 4 units. So this is the dose adjustment for insulin pump. Patients who are on continuous subcutaneous insulin infusion pumps. So this is the way to adjust the basal rate and bolus rate. So for basal rate, decrease the dose by 20 to 40% in the last 3 to 4 hours of fasting and increase the dose by 0 to 20% post iftar. And bolus rate is mainly dependent on carb counting, and insulin sensitivity factor would apply here. So if hypoglycemia is occurring, blood glucose is less than 70, break the fast, recheck within 15 minutes if sugar has reached to 70 to 90 milligrams per DL. If blood glucose is more than 300 milligrams per DL or symptoms of hypoglycemia, hyperdehydration, or acute illness occur, patient should be advised to break the fast. In case of diabetes and pregnancy, pregnant women, regardless of their fasting status, need to sustain the standard blood glucose targets. We all know that there are stringent control for pregnancy. So fasting should be somewhere between 70 to 95, and 2 hours post meal should be less than 120. They should also break their fast if following symptoms occur, which I've already explained. So in elderly, it was seen that hypo was reported in 17%, those aged more than 65, especially if sulfonylurea are used. So those should be adjusted for sulfonylurea as well before Ramzan in elderly population. Post-Ramzan follow-up is very important to discuss the experiences, any complications to the scenario. This is a case of 55 years old male who is diabetic for the last 8 years, hypertensive, CKD with EGFR of 31.3 and HbA1c of 8. His BMI is 26 kilogram per meter square. He is currently on multiple oral anti-diabetic drugs. His drug regime include glimepiride at a dose of 3 mg BID, empagliflozin 10 mg once a day, sitagliptin 50 mg once a day. He wishes to fast during Ramzan, which is just a week away. What advice will you give and what adjustments will you make in these medications? Can anyone tell me what is the risk assessment score in this patient? Is he falling in low risk, moderate risk, or high risk? High risk, right. So what will you do? Should we stop his glimepiride altogether and add glucophage? Is he at a good control or poor control? Poor control. So the desirable HbA1c target is less than 7.5. So he is not at a good control. We cannot altogether stop his glimepiride. Next is stop glimepiride and increase the dose of empagliflozin. So he's just a week away from Ramzan. As I already told, we cannot titrate SGLT2 so early. Reduce seri dose of glimepiride and add basal insulin at a reduced dose. Reduce seri dose of glimepiride and continue rest. Since he is not at a very good control, so C is the most favorable option, that reduces seri glimepiride and add basal insulin with frequent SMBG monitoring. However, basal insulin should be started at a low rate, reduced dose. That's it from my side. Thank you so much. Now I would like to invite Professor Tasneem Ehsan to deliver her talk on management of type 1 diabetes during Ramzan.
Meri presentation. Assalamu alaikum again. So coming at the fag end, just I stand between you and meals. So I'll try and be as quick. This is not going to be difficult because there's so many slides that have already been shown. So a lot of ground has been covered now. And we did a little swap of topics, and I came at the end, not because it's the least important, but this is the least frequent situation that we encounter with diabetes. Type 1, remember, is not the common type of diabetes in any country, but it is nevertheless the more dangerous kind, especially during Ramzan. So type 1 diabetes, just this is the scheme of how I will proceed. A little introduction, risk stratification. We've talked a lot about that. Management of individuals with type 1 diabetes, the various insulin regimens, and a little bit about continuous subcutaneous insulin infusion through a pump. Now, we keep talking about pump now for, if most of you are general practitioners here, pump is not your problem because it is so expensive that it is really be in a consultant diabetes practice that somebody would be monitoring or supervising pump therapy. So don't worry your head too much about it.
एक अनाउंसमेंट है गाड़ी गलत खड़ी हुई है तो उसकी की लेंगे
जी जी बिल्कुल
अच्छा एक अनाउंसमेंट है कि ASL 695 ये गाड़ी गलत पार्क हो गई है की हमें दे दें वो हम सेट कर देंगे सॉरी मैडम प्लीज कट
Okay. So after that, so for all individuals with type 1 diabetes, it is better not to fast. So that is the advice as doctors that we're going to give. Because it carries a high risk. So अगर आप वो score देख लें तो 2-3 चीजों में ही 6 से ऊपर चले जाते हैं people with type 1 diabetes. So that's your standard advice to anyone with type 1 diabetes. The other thing that we know about type 1 diabetes and Ramzan through the various studies is that the analogs are better than conventional NPH and regular insulin. And but however, analogs are a little more expensive. So I don't know, again, in our country, this is what patients can afford is very important. For fasting, particularly the insulin pumps and the continuous monitoring that goes with it, the CGMs and the pumps have been shown to be very useful. And diabetes self-management education is not available to people. This is what the studies show, that most people do not have what is considered the standard diabetes self-management education facility. And without that, you cannot manage diabetes, type 1 diabetes with or without Ramzan. So this is a very weak link about how they're going to handle their diabetes. So these are things that we already know. What is new that we know through the studies, that various studies of type 1 and type 2 diabetes that Dr. Paris just mentioned? What we know the new information that we have is that risk associated with diabetes and fasting is not the same for all people. So even individuals with diabetes fall into that, can be stratified, and for some of them, it may be relatively safer. Since I'm talking about type 1 diabetes, somebody who is well educated in self-management, which means they know their disease, they know carb counting, they know what actions to take when there is hypo, then if they're all fully prepared, then the risk is not so much even for a type 1 diabetes. So it's not the same. The new studies show that some individuals with type 1 diabetes may have a lower risk and can safely fast, provided certain needs are met. And I talked about what the needs are. And evidence suggests that CGM can aid safe fasting, and sensor-augmented pumps have allowed individuals to fast for most of the month of the Ramzan. So sensor-augmented pumps are the pumps that have a continuous CGM, and it gives you alarms. It can suspend insulin delivery, and it is not difficult to understand that it will allow you or enable you to fast more safely. And now we have the newer pumps. I'll just briefly mention it later on. Fasting attitudes and outcomes vary considerably amongst different countries, and this is not difficult to understand either. We fall into the MENA region, and most of these research studies have been done obviously in the Muslim countries of the MENA region. There is some studies from India and some from Bangladesh, but most of them have been done in countries like, the Arab Emirates and Kuwait and Bahrain and these countries where the healthcare systems are very strong. They are very well developed healthcare systems. So the entire support network for a type 1 diabetes patient is there. So the education is there, the helplines are there, everything is there. So I would take these guidelines about safe fasting in type 1 diabetes studies. The evidence that has been produced through all of that, and a lot of the evidence is CGM derived. None of that is applicable to us. The diabetes self-management education is really, really weak, and the support system is really, really weak in our country. So take that with a pinch of salt. So what is missing in type 1 diabetes and Ramadan research? Adequately powered randomized control trials comparing different treatment regimens and algorithms for dose adjustments for type 1 diabetes during fasting. So we have experience, we have observational studies, but randomized control studies are not out there at the moment. Research on the impact of daily life on glycemic control can vary considerably among different countries for the reasons that I've already talked about. So in this MENA region, we have all the rich Arab countries, and we have some very good healthcare system countries like Iraq, Iran. And then I think we are the poorest people there, other than Algeria, I think. So the poorest country with the weakest healthcare system. Further research on fasting plans with consideration of type of various plans of eating and stuff, and duration and intensity of physical exercise. So here we are talking about physical exercise, the type of exercise, the duration, the intensity of physical exercise, and also the job requirements of exercise, various people with different jobs, demands of schooling. So there are children who go to a morning school, and then there are children who do the afternoon shift. And if they have type 1 diabetes and they're fasting, you have to factor that in also. And the dietary habits are so different here. And Dr. Sabah's presentation on, I would suggest all of you go on the net and go on the DAR website, IDF DAR website, and look at that Pakistani meal plan, what they're suggesting, and then think about what you're going to eat for your sehri and iftar, and just try and work out what calories that constitutes. So it's just a completely different story. So dietary habits, season in which Ramzan falls, and the duration of fasting. So it is going to be hotter and hotter as Ramzan proceeds, and the duration of fasting is going to get longer. So there are some cold countries where the duration is very long, but it is not so hot. And a validated risk score stratification method for adolescents and adults is, again, for type 1 diabetes, is still not quite there. Research into the quality of life, focusing on psychological effects of facing peer pressure in those who choose not to fast, and on the effects of acute complications during fasting. This is a point where I'd like to stop. With the intense focus on religiosity, we have appropriated to ourselves some of the functions of Allah Ta'ala. So, the reward or the penalty of fasting or not fasting rests with Allah Ta'ala. It does not rest with us. So if a young person is not fasting because he has type 1 diabetes or is having a hypo and needs to break a fast, for instance, here sitting amongst us, he's not going to go and eat in the toilet, in the privacy of a toilet. So we now feel free to sit on judgment on such people. That's not our role. That is not an authority that Allah Mia has delegated to any of us. So it's very important that we talk about that also as Muslims. So this is the global survey that Dr. Paris also alluded to. And in this global survey from 13 Muslim countries, a number of 1,054 subjects who were fasting, what they found was interesting results. This will absorb it. No. So when you look at duration of fasting during the month of Ramzan with type 1 diabetes who fasted, 26.8% were able to fast for 30 days. So that's great. About a quarter could fast for the entire month of Ramzan. 45% fasted for 22 to 29 days, and another quarter, a little over quarter, fasted for 21 days or less. In terms of hypoglycemia, 39.3% reported no symptoms of hypo. So that's a good number. I mean, if about 40% could fast without any hypo, then that indicates that good preparation was in place in these patients. 48% reported hypo of 1 to 7 days, and 12.8% reported hypos over 8 to 13 days. Mind you, this is a survey again from countries, Muslim countries with very good healthcare systems, not countries like us, like ours. Hyperglycemia was seen in, and hyperglycemia of more than 300 milligrams was reported in more than half the patients. More than half the patients did not report hyperglycemia of that magnitude, but 16.8% had hyperglycemia of that magnitude between 8 to 30 days. So a small proportion. These are well-prepared patients. Events leading to hospitalization, that is really good and encouraging. 93.2% did not require hospitalization, but 6.8% did. And that's to a higher percentage. And in our country, I'm sure the numbers will not look like that because we're least prepared to deliver that kind of care. So complications we've already talked about in the various preceding presentations. Hypoglycemia, hyperglycemia, DKA, dehydration. And dehydration, mind you, can also increase your risk of thrombosis. So spontaneous dural venous sinus thrombosis is also a possibility. CGM data study in adolescents with type 1 diabetes reported no difference in the duration of hypos during Ramzan. But then remember, this is a totally prepared, enabled patient, has a CGM in place, knows how to use it, knows his sugars minute by minute and day by day, and reacts to that through a pump mostly. Landmark studies have reported an average daily duration of hypo of 1.39 hours per individual, with approximately 70% occurring in the last 6 hours of the fast. That's a no-brainer. We know that hypos are more likely to occur, just as we approach close to breaking the fast. So you need to know your risk. This we've done already. Duration of diabetes, if you look at the table that Dr. Yahya very nicely bit by bit described to you, duration of diabetes is important. Why is it important? Why is the duration of diabetes important? Anyone? Anyone? Yeah, so the longer the duration of diabetes, not avoid, but the longer the duration of diabetes, the more the likelihood of complications being on board. So if somebody's just been diagnosed before Ramzan, they're likely to have good kidneys and good hearts and good everything else, likely, mind you, but they may not. Sometimes the diagnosis is also very delayed. So diabetes-related education. If a patient is competent in titrating his insulin, knows how to decrease, how to increase, knows his targets, knows how to deal with hypoglycemia, which is DSME, diabetes self-management education, then of course their risk will be very different from somebody who doesn't. The risk of hypos, the various drugs that are on board, CKD, if it is on board, the kind of work that they do, and all of those things. And hypoglycemia unawareness, remember, is very, very dangerous. Straight away gives you a score of 6.5 and puts you in the high risk category. So if a patient has any history like that, pre-Ramzan control is very important. We've talked about it. And motivation for SMBG. If you're not monitoring your glucose, you can't fast with type 1 diabetes. And 7-point monitoring is what, and complications are really a red alarm for you. You need to know what complications are born and whether they can do it or not. So criteria for fasting, pre-Ramzan review of glucose profile. If the HbA1c is more than 9, insulin regimen should be adjusted and reevaluated well before fasting. So that is about 6 to 8 weeks. You need a nutritional assessment, a review of carbohydrate intake, and guiding into proper food options for the 2 main meals. So here is a whole lot of work. Lot of work about carb counting, knowing the 15-gram portions of different food items that we eat. So there's a whole lot of education required, material to be given, patient to be practicing carbohydrate counting. And not just the patient who or the person who has type 1 diabetes, but people around that person, the carers and the guardians. So in these studies, children as young as 12 with type 1 diabetes have been fasting, but most of them are wearing pumps and CGMs, which allows people to intervene quickly. So frequent monitoring of glucose, self-monitoring, and if you have a CGM, then that's very good. And we keep talking about that cutoff, less than 70. That is when you must break the fast. You can't say, abhi 1 ghanta rehta hai iftar mein abhi, let it go. You must break the fast. This has been shown multiple times now. I don't need to go there, but 7-point plus anytime the patient is not feeling well. This is a CGM, and the one that is available in the city now is the Freestyle Libre, which gives you, that's the face of the reader on it, which you just take over the sensor. One sensor can be worn for up to 14 days. But again, expensive business. Once you've bought the thing, the monthly cost is close to 20,000. So a lot of money involved there. But the important thing is that if you see an arrow on the top right-hand side, you see an arrow in the upward direction. So this monitor also tells you that this sugar is going up. So it gives you a trend up or down. And when it's a vertical down, then it is falling very steeply down. So it allows you to take some action accordingly. So monitoring with the CGM is anytime superior to self-intermittent monitoring because it gives you information in real time and you can add to it. It helps in lowering HbA1c, in reaching an HbA1c target, decreasing glucose variability. So if you look on that monitor, you can see that there is a green broadband and a blue broadband. And this green broadband or the blue broadband indicate the set points for the lowest sugar and the highest sugar. And if you look at that curve, it is falling within that broadband. So this is showing very good control because if it's below that thing, that constitutes a hypo. And this gives you the new parameter that I talked about, the arrows. It gives you the time in range. And, for people with CGM and monitoring, there is a new measure that we look at in terms of diabetes, and that is glucose variability to see what is the maximum swing that happens, because that also impacts complications. And also the time spent within the specified range, which should be 70% or even more. And the hypo should be less than 4%. So you have different parameters when these are being used. So this effectiveness, of course, एक sensor 14 दिन के लिए होता है. So you don't have to wear it all the time, but maybe just wear it during Ramzan if you're fasting with it, or wear it and get your control sorted out and then not wear it. So there are many different options. The multiple daily injection regime with insulin. So basal bolus composition and timing. Approximately 40 to 50% of the total daily dose is given as basal insulin. Remainder is given as either short or rapid acting insulin divided between meals. This is the usual insulinization. And that's the kind of dose. I'm not going to go into the detail, but if this patient, if you're going to insulinize a patient, then for type 1 diabetes, initial daily dose is 0.2 to 0.4. You start with that dose, and then most people will require between 0.6 to 0.7 units. For type 2 diabetes, it can be much higher, but initial insulinization is like that. And I don't have the time to go into the detail. So the long-acting insulin can be given at bedtime or morning, but that is the basal analog. That can be given either at bedtime or it can be given in the morning. And especially if you're looking at glargine 300, it can be, you don't have to give it at night. Glargine U100 does not exactly last for 24 hours. So if you want the dose to wear off, then you want it to wear off close to iftar. And therefore, it's better that you have it either at your bedtime or you have it, better that you have it at bedtime or even, with iftar, not at sehri. NPH, if NPH is being used, then 2/3 of the dose in the morning and 1/3 at sehri or at mealtime. Pre-meal dose is determined by these factors, and I just pre-meal blood glucose level, meal size and content. And here Sabha has told you the plate, Sabha has told you the 15-gram portions, Sabha has told you the calorie value. You need to know how many calories and portions of carbohydrate I'm going to consume in this meal. And then look at your glucose trend if you have a CGM activity pattern, and then see what dose of insulin you are going to give. With effective carb counting, estimates of fat and protein, this is a bit more complicated because when there is fat and protein along with carbohydrate, it drives the glycemic index of carbohydrate down because it won't be absorbed very quickly. So not only that, and then when the protein and fat are converted to glucose, there may be a later peak of glucose. So that delays the increase in glucose if you have protein and fat in the meal. What about the insulin analog and the regular human insulin? So the analogs are anytime preferable for type 1 diabetes as well as type 2 diabetes, and especially in Ramadan. And why are they preferable? They've been developed in the last 25 years and they just keep getting better. So now you have not just a short-acting analog, you have an ultra-short-acting analog, which onset is even quicker, duration of action is smaller, covers the meal and goes off. It has a quick onset and shorter duration of action, so hypos are likely to be less with this. The basal insulin analogs have a longer duration of action, longer than the 12 to 18 hours that you have with NPH. But with U100, like I said, it is not usually totally 24 hours. It has a flatter, more constant plasma concentration as compared to NPH. And this is a very beneficial effect because normally NPH has a peak. That peak during daytime coincides with the lunchtime meal. So hypos are unlikely. But if you take it at night, then, there may be a midnight or early morning peak that is not covered and hypos may happen at that time. And this is why it is not the best of insulins to take. So it is not surprising, though, that type 1 diabetes treatment with analog insulins gives you slightly less, significantly less hypos, less weight gain because the insulin dose is lesser, and lower HbA1c versus human insulins. This is a long-acting versus intermittent-acting insulin meta-analysis of 39 studies, and it gives you interesting things that long-acting insulin is statistically significantly superior to intermediate-acting insulin from glycemic control point of view and from the harm point of view, which is, I've already told you, that there is less weight gain with it and there is less severe hypos. But in terms of micro and macrovascular complications, there is no statistical difference, but these are, of course, more costly, and this is most important for us. And here is the slight difference in HbA1c that you can see with Detamir or Levemir use as compared to NPH use in a 108-week study where the HbA1c was slightly higher with NPH compared to Detamir. I'm not going to go into this. This has been discussed in great detail, but have this sitting in your clinics. We're going to give everyone a copy of it. It is available on the net. And, risk stratify your patients, know what category of risk this patient has, give them appropriate advice, and then go along. So now I'm quickly going through the management guidelines for these patients. Patients can be on conventional twice daily NPH and regular insulin. They may be on a pre-mixed insulin. Actually, no patient with type 1 diabetes should be on pre-mixed insulin, because if they're on pre-mixed insulin, they cannot titrate their insulin. It only has 30% of the dose is the prandial insulin. So if you're going to have a large carbohydrate meal, you can't increase your prandial insulin, because every time you increase it, there will be 70% increase of the basal insulin. So that is not the insulin that a type 1 diabetes patient should be on. So basal bolus is the best regime to have, and that is meal-adjusted bolus. Meal-adjusted bolus means you're going to be doing carbohydrate counting and adjust according to your blood glucose level and adjust. So subcutaneous, I will not talk much about. Safety and efficacy of the first generation analog basal, it has been proven, that is Glargine U100, in a number of studies, should be administered earlier in the day. So, if you don't take it with iftar, then at least take it with your evening snack or take it before you go to bed. Decrease pre-Ramzan basal dose by 20%. So we keep saying this again and again, reduce your basal dose. And the second generation analogs, U300 and Degludec, we do not have evidence, randomized controlled evidence for them. Having said that, a lot of your type 1 patients will be on the U300, which is available in this city by the name of 2U. There is no need to shift them to U100 Glargine. You need to continue with that. It's a good insulin. It is a flatter curve. It is a better 24-hour cover. What about the analog? Evaluation of carbohydrate intake and blood glucose readings are important for proper dose estimation. I keep saying this. Bolus dose is based on carb counting, and then not just carb counting, you need to do the insulin carbohydrate ratio, which is dependent on insulin sensitivity factor, and that varies between different meals. The bolus dose should be given, so even with analog insulin, it is not given immediately before eating. It is injected best injected some 15 to 20 minutes before the meal. So inject before iftar break, about 15, 20 minutes before that. And that does not invalidate your fast, because it neither rehydrates nor does it give you any calories. And high pre-meal blood glucose level in the evening may require an extra corrective dose, because if people keep eating, then you may have, a very high glucose, and you may need to give, because this is rapid and short acting, you may need to give a little bit of more bolus insulin, but don't inject more frequently than every 3 hours, because then you get stacking. Dr. Paris described the concept of not increasing your insulin doses more frequently than every third day. That is actually because when you control blood glucose and the sugars come down, the glucotoxicity decreases and the dose of insulin you're giving becomes more effective. So you may have a hypo if you keep increasing the dose every time. So not more frequently than every third day. Bolus dose adjustment. So I can't go through this, but this is a formula, and there are now calculators available on the net and apps through which you can calculate. So this is the calculation for insulin sensitivity factor, depending on whether you're using the rapid acting insulin or the standard insulin, and that's a constant divided by the total daily dose of insulin, and this gives you the correctional dose. And then you determine step 2 is the insulin sensitivity factor. Again, a constant divided by the total daily dose. And then you add the 2 up to give you the dose of the bolus that you have to inject. So I don't want to talk too much about the pumps, but most studies in insulin infusion pumps have shown that during Ramzan, you will need to reduce the pump or the total amount of insulin by 10 to 20%. And some studies propose an increase of basal rate during the eating hours and reducing the basal. You can do that with a pump. So a little more basal insulin going during the eating hours and less going during the fasting hours. So you may give boluses covering pre-dawn and iftar. And bolus doses of insulin can be delivered in 3 patterns. This is a bit complicated, but if I had a pointer, I would show you. One is the standard bolus, the peak that you give when you're about to eat. The second is when there is fat and protein in the meal, so you give some insulin as a bolus and some over a longer period of time. And that is a combination bolus. And then there is another long square bolus, which is the last picture. The long square bolus is when the carbohydrate content is too low and you're mostly taking protein and fat. So there are different ways you can deliver your bolus. Meals with a higher content may need an extended or the combo bolus. It is recommended to use bolus calculators. Like I told you, they're available for correcting the dose of insulin. So I'm not going to talk too much about this, but the newer pumps, the hybrid pumps, which are now coming with the sensor, and the sensor and the pump, they are talking to each other, and the pump has an inbuilt artificial intelligence-driven algorithm. The patient has to do nothing. They don't have to deliver that bolus or design that bolus or calculate anything. The pump calculates it for you, and it just keeps on working nonstop. So it's like having an artificial pancreas. You have another pancreas. That's the automated delivery system, and I've just mentioned the time and range to you and given you the points. So this is another of the same kind of pump systems that's coming. Very quickly, this has already been done. I'm not going to talk about CSII, but MDI, bolus and basal. So what you're going to do is 30 to 40% reduction in the basal insulin dose, and it should be taken at iftar or after iftar, but not at sehri. Rapid and analog insulin reduce the sehri dose by 30 to 50%. And omit the pre-lunch dose and adjust the iftar dose according to your carb counting and meal size and so on. And if you're self-monitoring, then do a 7-point curve. If you're using NPH and regular insulin, then pre-Ramzan NPH morning dose to be taken in the evening, 50% of the pre-Ramzan evening dose to be taken at Sehri. And for regular insulin, Paras has actually already gone into it, so reduce the dose at Sehri. But you can have the same dose or more dose if you pre-mixed. I don't want to talk much about, but again, 50% reduction. This we have already covered again and again. Remember that 70, repeating at between 70 and 90, breaking fast at more than 300 or whenever symptoms occur, and very quickly 2 cases. So I'm sure you will get this. Type 1 diabetes since the age of 5 years. She's now 22. Wishes to fast during Ramzan. So many years of type 1 diabetes. Her BMI is 24, so she's not fat, just a little overweight. And on multiple daily insulin injections, so basal and prandial. Her glucose control has always been on target, between 7 and 7.5%. No episodes of DKA and only very occasionally predictable episodes of hypo. So meal has been delayed and she has a hypo, so she knows what to do. Her current insulin regime is as follows. Glargine, 20 units at 10 a.m., and that is U300. And the glulisine is 12 units analog insulin, which goes by the name of Apidra, 12 units pre-meal 3 times a day. How will you adjust her insulin during Ramzan? So here are 5 choices. Switch to a pre-mixed insulin formulation. reduce basal and bolus dose by 40 to 50%. HbA1c is on target, so switch to oral anti-diabetic drugs during Ramadan. Reduce basal dose by 30 to 40% and adjust bolus doses according to insulin carb ratio and insulin sensitivity factor. Switch basal insulin to degludec, which is analog 24-hour insulin, not available here, available abroad as Tresiba, here in a pre-mixed formulation by the name of Rysodec, and adjust prandial dose according to SMBG. So let's look at the first option. Switch to pre-mixed insulin. Yes, no? No, good. Reduce basal and bolus dose by 40 to 50%. No. Okay, I'm good. There are no other result. HbA1c is on target. Switch to oral anti-diabetic agents. Absolutely no. So somebody said no. But it still happens. It still happens. Patients go from doctor to doctor and the good doctor says, insulin बंद कर दें आपकी sugar ठीक है tablet ले लें. Patient भी खुश और doctor भी खुश. But that's an ill-educated patient. They should know that insulin can never be stopped. Reduce basal dose by 30 to 40% and adjust basal bolus doses according to ICR and ISF. Yes. Switch basal insulin to degludec and adjust prandial dose according to SMBG or ICR, ISF. Why not? Suppose it was available. What would you do then? Sorry? D is the best option, but I want to know why is E not an option? Sorry? Prandial to दोनों में हो गई है, D में भी और E में भी, but why is this not an option? कौन बोल रही है? Okay. More chances of weight gain and hypoglycemia? But that's fine. Prandial को तो adjust कर रहे हैं. Basal को भी. There's another catch there. I want somebody to pick it up. Anything else?
Dose is not adjusted.
Okay, one could be that we're not adjusting the basal dose, and that's the first thing we need to do. Or what is degludec? It's a long-acting basal insulin. So U100 का तो हमारे पास एविडेंस है. ये दोनों चीजें जो डेग्लूडेक है और U300 है, इनके अगर आप प्रोफाइल्स देखेंगे एक जैसे हैं. ठीक है? We don't have experience with degludec. So this patient is already taking U300 insulin for basal insulin. There is no reason why you would want to change a flat, long-acting basal insulin to another flat, long-acting basal insulin. So the thing is, you don't make unnecessary changes to their regimen. It's another thing that we don't have evidence for degludec, and we also don't have evidence for U300. And these are longer acting insulins, and how they will behave with fasting is something that still needs to be studied. But if you have a patient already taking it and is stable on it, and you reduce the basal dose and make sure you give it with iftar or around iftar or shortly after that, you're probably okay with U300. But there's no reason to change it to degludec. Let me give you, this one's even easier. So this is another one type 1 diabetes patient, but this one's 50-year-old. And he also has hypertension and he has chronic kidney disease. He's on pre-mixed conventional insulin twice daily. ये हमारे यहाँ का common scenario है. No type 1 patient should be on pre-mixed insulin. His diabetes is poorly controlled with an HbA1c of 8.8%. His Ramzan risk assessment score is 10. He insists on fasting, which is 8 weeks away. So even though he should not be fasting, there are too many red flags here. But he says, आप कुछ भी कर लें, मैंने रोजा तो रखना है, जिंदगी मौत अल्लाह के हाथ में. So आपने अब इनको help करना है. तो आप इनको जो help करेंगे, तो आप क्या कहें? Can fast with minor adjustments to treatment? No. His risk is moderate and he can be advised to fast? No. adjust his insulin regime because he's come to you 8 weeks before that, switch to MDI analogs and reassess after 2 weeks with blood glucose charting. Doable? Okay. Increase the dose of morning pre-mixed insulin at iftar by 30%. Not really, because he's already poorly controlled. Maintain current dose of evening pre-mixed insulin at iftar. No? Or Seri? No? Okay, so the answer is C. Shift him to an analog insulin, do it multiple dose so that you can adjust. See him quickly in 2 weeks with sugar charts and see where you can get in and help him. With that, I move to my last slide, which is actually also in many ways more important than what we've been doing so far. Don't just fast, eat and pray this Ramzan. Try to follow the teachings of Quran and Sunnat. And it's much more than just fasting and eating and praying after that. Above all, try not to lie, to deceive people, to connive against people, to hurt other people, whether it's physical hurt or emotional hurt. Be harsh with people and hurl profanities or abuses at people, and lead a life and try not to lead a life of overindulgence. So overindulgence in eating, in whatever you do. Darmiyana Ravi, this is what our religion tells us to do, especially in eating. So since we are talking about Ramzan, but I don't want to focus on food in this slide. I want to focus on everything else, whether how you spend your money, so think about that also. And above all, try and help the people who are around you as you go along in life. So with that, we conclude today's seminar. Thank you very much. You've been a great audience. Everybody has been very attentive. I hope we have fulfilled our promise of, giving you some knowledge about Ramzan. There's so much out there. We had to try and, get you the most important things. And now all that is left is to eat some more. Thank you very much. Dr. Paras. Thank you. Oh, so we have questions. Are there any questions? Okay.
Gigi.
Let's all of the speakers please come on the stage and we can answer from there.
Hello. So I have two questions, one from Professor Tasneem Hassan and one from Dr. Paras. So Dr. Paras, as you mentioned in your presentation regarding the dose titration in insulin pumps, you said we need some dosage adjustment. So when the CGM is attached with the insulin pumps, so there is the non-dose titration, because when the sugar is go up, the insulin automatically go inside the body. Okay, and one thing more, you did talk about the GLP-1 and SGLT2. So can we use both together during fasting patients who are interested to get the fasting? See SGLT2 and as well as GLP-1.
Okay, so for your first question, the bolus rate will not go up itself. You have to pre-adjust it. As I mentioned, and basal rate should be reduced by 20 to 30%, especially in the last hours of fasting, and increased immediately after iftar.
You're talking about insulin pump?
Yeah, for pumps. And for your second question, yes, as SGLT2 and GLP-1 agonists can be used together. We do prescribe together, but not immediately before Ramzan. At least 2 to 3 months before Ramzan, with the advices that I already mentioned in my presentation.
I'm talking about GLP-1 like semaglutide or
Yes,
dulaglutide.
absolutely. They
But
can
you
be
know,
used.
both having the tendency for the blood reduction, and one patient is interested for the fasting, and already to reduce the weight. So is this, I think, complicated?
I think you are being confused with DPP-4 inhibitors. Maybe.
No, I'm not.
DPP-4 and
SGLT2
yeah, they both can be used together.
and GLP-1 weekly basis.
Yes, DPP-4 and GLP-1 agonists have similar mechanism.
I'm
of
talking
action.
about injectable.
Yes, they can be used
Okay.
if pre-titrated appropriately.
Let me just get in on the same question. The pump question that you've is creating a little confusion. The first generation of pumps that were available in this country, you have to deliver your own bolus. You calculate your carbs and you deliver your own bolus before eating. The pump doesn't do it automatically. You check your sugar and you deliver the bolus. And that's why I showed you the different kinds of boluses that you can deliver depending on the kind of food you have on your plate. The newer pumps, the hybrid pumps that are talking to the sensor, the fully automated pumps, and now they're even a better version. So the newest one actually is pretty much like an artificial pancreas. You have to do nothing. There is an algorithm within the pump which knows the sugar, adjusts your insulin dose. It doesn't even have a hypo alarm because you're not required to do anything. The hypo is something that the sensor will sense, tell the pump will stop insulin delivery well before the hypo happens. But even in the second generation pumps, there was the low glucose suspend and the predictive low glucose suspend, जिसमें alarms थे, जिसमें आपको action लेना था, कुछ खाना था, कुछ पीना था. तो low glucose suspend में खुद से insulin suspend हो जाती है for जब वो देखता है कि ग्लूकोज लो हो गया, बट हाइपो होता है, अलार्म बजता है, पेशेंट को कुछ करना होता है, इंसुलिन डिलीवरी रुक जाती है. बट प्रिडिक्टिव लो ग्लूकोज सस्पेंड व्हिच वाज अ लेटर मॉडल, उसमें पंप को ये आइडिया हो जाता था कि ये शुगर गिर रही है, इस रेट से गिर रही है, हाइपो होने वाला है. सो वो आपको वार्निंग दे देता था कुछ खा लो पहले से ताकि हाइपो हो ना. और जो न्यूअर पंप्स हैं वो तो टोटली ऑटोमेटेड है, यू डोंट हैव टू डू एनीथिंग. There is no, you can absolutely give SGLT2 and GLP-1 together. And जो आपका standard patient है type 2 का और even type 1 का, many of them, वो पतला है, good weight पे है या मोटा है? पतला है?
पेशेंट की बात करिए ना.
जी जी, पेशेंट की.
मतलब जो है, he is not obese.
आप उस पेशेंट की बात कर रही हैं जो कि पतला है या अंडरवेट है?
अंडरवेट है मैडम.
सो अगर अंडरवेट है तो फिर तो अंडरवेट है और तो इंसुलिन पे होगा probably.
Type 2 patient, ठीक है ना?
But type 2 patients who are underweight are usually people who've had type 2 diabetes for a long time and actually have insulin deficiency. So you should be very careful about those patients जो type 2 पतला है. But आपका standard patient तो एक मोटा patient है. And Ramzan is a very good opportunity to lose weight and add to that drug treatment which helps him lose weight. And GLP-1 is hypoglycemia safe because it works through it in a glucose dependent manner. It is relatively safe. So are SGLT2 inhibitors. वो तो spilled glucose को वो dispel करते हैं. But when there is a secretagogue on board or insulin on board, then those doses should be revised अगर hypo का वो है. But the two can be given together absolutely. Second question कोई पूछ रहा था?
मेरा क्वेश्चन इसके मतलब ये है, अगर SGLT2 inhibitor causes the excretion of glucose as well as sodium, so it also causes the passive loss of the water, so patient suffer with dehydration. Patient would suffer from dehydration having a fast in Ramadan.
So अगर आप SGLT2 inhibitor इफ्तार पे लेंगे, the majority of diuresis will happen during the eating hours. And when an SGLT2 inhibitor is on board, you have to emphasize the need for hydrating properly. People should drink enough water. That's what you need to emphasize.
Enough water also causes, madam, diuresis.
Even if, so what are you going to do?
मेरा क्वेश्चन ये है कि is it not contraindicated in diabetic patient if he or she is taking a SGLT2 inhibitor?
What is not contraindicated? Fasting is contraindicated, ये कह रहे हैं आप?
मैं ये कह रहा हूँ कि अगर वो पेशेंट SGLT2 इनहिबिटर पे है,
जी जी,
अगर उसको हम उसकी ड्रग चेंज नहीं कर सकते हैं,
किस
उसकी पेशेंट की जो जो रमजान में रोजा रख रहा है,
इसलिए कि उसने रोजा रखना है?
हाँ.
Do you want to answer that? No. Since you did the topic, you answer it.
So patients who are on SGLT2 inhibitors, well controlled, and if they are going to fast, just advise them for increasing the fluid intake during non-fasting hours. No need to stop the drug if he is on good control. Fluid homeostasis has been well explained. No need to stop. And drug should be taken at iftar.
And like she said, don't start it just before Ramzan. You need to understand and figure out how it's going to work with that patient. So have it at iftar. There's going to be diuresis. Patient will feel thirsty, and ask them to drink a little extra water during the eating hours.
So my question is from Dr. Yaya. A patient who is obese, 47 years age, and type 2 diabetic, and mostly HbA1c is 9%, and he is not planned or going to visit any doctor before Ramzan. He just started and suddenly he decided that he will fast. And during first or second roza, he feels reactionary hypoglycemia. What should you say?
Well, first of all, if he's not visiting any doctor before Ramadan and once he has developed hypoglycemia, his medical risk score is not known, and you're talking about uncontrolled sugars touching more than 9%, and now a patient is landing